Hello everyone. Today's class is all about adrenergic nervous system. So in the previous classes, we have started off with autonomic nervous system, and you're all very much aware that your ANS consists of two major divisions called as the parasympathetic nervous system and the adrenergic nervous system. Now, the terminology adrenergic nervous system, also called as the sympathetic nervous system, this should be more precisely called as the noradrenergic nervous system because it is norepinephrine or noradrenaline, which is the major neurotransmitter. Now, imagine a situation wherein you're chased by a wild animal. What are your reactions going to be? Obviously, you're going to run for your life. So, what are the things which support you in this escapade from this wild animal? Have you ever thought about it? So, first, you need to see better. That is why your pupils are dilated. Then, you have to have an increased heart rate, increased cardiac function to pump the adequate amount of blood to your organs, especially to your limbs, which help you to flee. Next, there is release of epinephrine or adrenaline from your adrenal gland. There is an elevated blood pressure mainly because of your increased force of contraction and also your increased cardiac output. Obviously, there is going to be a slowdown of your digestive process and also the urinary system. You can't be taking a loo break in between while you're running, isn't it? It's as simple as that. Then your lungs, they have to be dilated to help you breathe well. And then glucose needs to be mobilized. This is to provide energy. So mobilization of glucose, it mainly happens because of glycogenolysis. There is no newer formation of glucose, that is, there's no neoglucogenesis. Now, all of these things are happening even without your knowledge. Have you ever thought what is responsible for maintaining this so-called as the flight or fight response? So it's nothing but your adrenaline, which is called as the wonder hormone, which helps you or which gives you the momentum to face a fight or a flight sequence. So in today's class, we shall be talking about sympatho-mimetic drugs or your adrenergic drugs. So what are your sympatho-mimetics? Those which mimic the action or the effect of adrenaline on the body are called as sympathomimetics. So as I mentioned, the sympathetic system consists of three major endogenous catecholamines. I always call them as the three musketeers. And this includes noradrenaline, adrenaline, and dopamine. These are the endogenous catecholamines, please remember. And I suppose in the introduction class, you have come across that the adrenergic system, the outflow is called as the thoracolumbar outflow. Fine. So there's one more, like most of the times you hear us using the names norepinephrine, epinephrine, noradrenaline, or adrenaline. So is there any difference between them? Definitely not. It's just the nomenclature. One is the UK pharmacopoeia nomenclature or the UK nomenclature, and the other is the US nomenclature. So both of them, norepinephrine, noradrenaline, or adrenaline or epinephrine, means the same. So the endogenous catecholamines, remember these three of them, they're very essential. Now, all your neurotransmitters, I think you've studied about this even in your parasympathetic nervous system, how acetylcholine was synthesized within the neurons. So obviously, norepinephrine is the major neurotransmitter which is being synthesized in your adrenergic neurons. So Synthesis of norepinephrine is present there in almost all the adrenergic neurons, whereas adrenaline is only secreted by the medulla, that too, that is your adrenal medulla, that too when you are faced with a situation of flight or fight. Otherwise, norepinephrine is the universal neurotransmitter. Now, the synthesis, the synthesis of adrenaline, it takes place by the amino acid tyrosine. Now, this tyrosine is acted upon by tyrosine hydroxylase. Tyrosine hydroxylase acts to give rise to DOPA. Now, DOPA is acted upon by again DOPA decarboxylase. So, DOPA decarboxylase is a non-specific enzyme, and it is also responsible for conversion of 5-hydroxytryptophan to 5-hydroxytryptamine. So, DOPA decarboxylase is a non-specific enzyme. So, in that process, dopamine gets synthesized. Now, dopamine is taken up by your vesicles, and over here it is converted into norepinephrine by the action of enzyme beta hydroxylase. Now, this norepinephrine is stored within the vesicle in conjunction with your other co-transmitters. So, you know about co-transmitters. With norepinephrine, you have ATP, substance P, enterochromaffin, along with the enzyme DOPA decarboxylase. And then, in response to a neuronal activity, there's release of calcium, and this calcium helps in the fusion of this vesicle with the synaptic membrane. So this results in release of norepinephrine into the synaptic cleft. So metabolism. Now the norepinephrine, which is present within the synaptic cleft, either acts upon the postsynaptic receptors or it is rapidly uptaken. Okay, this is called as reuptake phenomena, or it is acted upon by the enzyme monoamino oxidase. Then the release of norepinephrine is regulated by many autoreceptors. Okay, so there are the presynaptic receptors which are present on the neurons, and this is responsible for regulating the further release of norepinephrine. One more thing, what you have to pay attention over here happens to be your uptake 1 and uptake 2. So I'll be talking about that. So before going further, how are these catecholamines metabolized? Now, as I told you, the norepinephrine, which is released into the synaptic cleft, is acted upon locally by the monoamino oxidase enzyme. That which is present in the plasma is acted upon by catechol O methyltransferase. Now, both of these enzymes give rise to many intermediates, and these, the assay of these metabolites could be helpful in analyzing in one of the diagnosis of one of the conditions which is called as pheochromocytoma. Okay, so this is how the metabolites of adrenaline are being formed. So normetanephrine, metanephrine, and 3,4-DHMA, these are your metabolites which are excreted in urine. And let me tell you, in contrast to your acetylcholine, which is acted upon by a cholinesterase enzyme, which terminates its action, contradictory to that, adrenaline or norepinephrine termination of action is not significantly brought about by metabolism. Then, how is the termination of action occurring? It's mainly by this process of reuptake phenomena. So, something which terminates the action of a neurotransmitter is one of the key areas wherein you can channelize your discovery of drugs. That is why for acetylcholine, we have drugs which modulate the effect of cholinesterase enzyme, if you remember. So similarly, for adrenaline and norepinephrine, we have drugs which modulate the reuptake phenomena. So this is something which is practically very important. Okay. Then talking about, sorry, then talking about your reuptake phenomena. So there are two types of reuptake phenomena. One is your axonal reuptake and the other is your vesicular reuptake or the extraneuronal uptake. So axonal uptake is brought about by the norepinephrine transporter. Okay, and then extraneuronal uptake is brought about by your organic cationic transporters. Okay, so when I talk about the drugs, I'm going to explain it to you further. Then the postsynaptic adrenergic receptors are your G protein coupled receptors. So the action of your neurotransmitters are brought about either by increasing or reducing the cyclic AMP levels, or it could be through your GQ pathway, your IP3 DAG pathway. Adrenoreceptors. So these are classified into major two types: alpha receptors and beta receptors. Now, alpha adrenergic receptors are again classified into two subtypes, alpha 1 and alpha 2, and beta receptors are classified into three major subtypes, beta 1, beta 2, and beta 3. Alpha 1 receptors are further classified into subtypes like alpha 1A, 1B, and 1D, and alpha 2 receptors are further classified into 2A, 2B, and 2C subtypes. So how did they arrive at this point? It's mainly by the relative organ specificity of the selective agonists and antagonists. Fine. To understand the action of the alpha receptors or the pharmacological effects, we need to know how are these, subtypes, where are they present, and what is the function. So alpha receptors, they are predominantly present on your vascular smooth muscles. So over there, they are going to bring about vasoconstriction. So by causing vasoconstriction, they are going to increase the total peripheral vascular resistance. And these alpha receptors, they are also present on your heart, on your Purkinje fibers or bundle of His, and also within your nodes. Okay, so over there, they're going to increase the slope of the depolarization which occurs. So because of that, they have this capacity for generating arrhythmias. Then, as I already mentioned in the introduction, eyes, the pupils need to be dilated. There are two types of receptors within the eye. One is the M1 receptor, which is present on the constrictor pupillae. Sorry, M3 receptors, which are present on the constrictor pupillae, and alpha 1 receptors, which are present on the dilator pupillae. So when the alpha receptors act, this is going to pull or contract the radial muscles of the iris, thus bringing about dilatation of the pupil. Next is the action on aqueous humor. Now, alpha receptors are known to reduce the aqueous humor production itself. So that is why we use adrenergic prodrug of adrenaline, which is called as dipivaphrin. This is mainly because adrenaline, when you instill as drops, it's not going to penetrate the cornea. Endogenously, it can act, but when you administer it from outside, it is definitely not going to act on the across the corneal barrier. So for that reason, we use a prodrug which is called as dipivaphrin. Again, you're going to be learning about this in during the class on glaucoma. Then these alpha receptors, they're also present in the gut. As I told you, they cause relaxation of the smooth muscles. But at the same time, alpha 1 receptors are present on all the sphincters, be it the urinary sphincter or your large bowel sphincters, there is going to be contraction of the sphincters. Because of that, there's no voiding of urine or evacuation of bowel. So genitourinary system, what are they going to do? The trigone is contracted and the detrusor is relaxed. So because of that, there's no voiding of urine. But these alpha receptors present on the prostate are one of the vital receptors for bringing about ejaculation. Then the other action of alpha receptors happen to be in the non-pregnant uterus, splenic capsule. So by contracting the splenic capsule, the RBCs are sent into the circulation. On the salivary gland, again, it is, it causes enhanced action, secretion. So liver, there is enhanced glycogenolysis. Alpha 2. So we talked about alpha 1 receptors. Now talking about the alpha 2 receptors. Now these alpha 2 receptors are the GI by GO type. So, and importantly, they are present as autoreceptors. So autoreceptors always, they regulate the release of the neurotransmitter from the neurons. So these autoreceptors within the brain, okay, they are present centrally, and when they are present centrally, they are going to reduce the sympathetic outflow. So because of this, there's going to be a reduction in the BP. So centrally acting sympatho mimetic drugs like clonidine, alpha 2 agonists, they are used in the treatment of hypertension. And these drugs, because of their inhibitory action, they also tend to cause sedation, and they could also be used for analgesia. So on the pancreas, again, alpha 2 receptors are present, and they're going to reduce the insulin production. And when these alpha 2 receptors are present post-junctionally, they are present at the blood vessels and also at the platelet. Yeah, this was the explanation about the autoreceptors. So these autoreceptors are presynaptic and they are prejunctional. Activation will always lead to inhibition of the neurotransmitter release. This is like a negative feedback, but there are exceptions to the rule. The main things are your nicotinic autoreceptors, beta 2 autoreceptors, which in fact facilitate neurotransmitter release. The next thing is about the beta receptors. Now, beta receptors are again of three types: beta 1, beta 2, and beta 3. Beta 1 receptors are mainly found on the heart and at the juxtaglomerular apparatus. So, on the heart, what do? So, these are mediated through GS, that is enhanced cyclic AMP levels. So, by activating the myosin and the actin filaments, so it is going to enhance the force and the rate of contraction. They are also increasing the AV conduction. So because of that, the refractory period is reduced. What is the action of beta receptors at the juxtaglomerular apparatus? They're going to enhance the renin release. So, and by enhancing the renin release, the renin angiotensin aldosterone pathway tends to get activated. Because of that, there's going to be a sodium water retention, and this in turn leads to elevation of blood pressure. They also have the antidiuretic hormone like effect. And beta 1 receptors also tend to cause some amount of lipolysis, whereas it's beta 3 receptors predominantly involved in lipolysis. So this was the action of your beta 1 receptors. Now, where are your beta 2 receptors present? So similarly to your beta 1 receptors, even the action is modulated by your GS type. So they increase the cyclic AMP production. So these beta 2 receptors, they are present on the smooth muscles, vascular as well as non-vascular. So when they act on the vascular smooth muscles, they're going to cause vasodilatation. Please remember, when you give adrenaline, at lower doses, it is always the alpha receptors which are highly sensitive to adrenaline. So you see vasoconstriction. But as the when you give it IV at a very rapid concentration, at a high concentration, it's your alpha receptors which are very sensitive. But as the concentration falls, your beta receptors tend to get activated. Beta 2 receptors tend to get activated, and this in turn leads to a slow and a sustained vasodilatation and a fall in blood pressure. Now, on the other non-vascular smooth muscles, you have your lungs where they cause bronchodilation, and also on your GIT where they cause relaxation. The other effects which can be seen because of beta 2 mediated action involves the skeletal muscles where you can see tremors. And then at the liver, again, your beta 2 action leads to enhanced glycogenolysis, increased gluconeogenesis, enhanced glucagon secretion. And as I already mentioned in my previous slides, beta 2 receptors or your autoreceptors, and contrast to your alpha 2 receptors, they facilitate the neurotransmitter release. Beta 3 receptors. Now, these beta 3 receptors, again through GS, and they're predominantly acting on the adipocytes and they bring about lipolysis. So this is required for calorigenesis, and they also tend to enhance your free fatty acid levels. So one of the the agonists are one of the promising anti-obesity drugs, but again not significant breakthrough. Then this one, to understand the pharmacological actions, you have to know the action of some of the endogenous catecholamines and also the synthetic catecholamine on the various organs or at the receptor level. Now, adrenaline is an agonist at alpha 1, alpha 2, beta 1, beta 2, and a weak beta 3 action. Whereas noradrenaline has just alpha 1, alpha 2 action, beta 1 action, but no beta 2 action. This is something what you have to remember. Isoprenaline, on the other hand, does not have any alpha action, absolutely no alpha action, but only beta action. That is on beta 1, beta 2, and beta 3. So it's a selective beta agonist. It's going to act only at the beta receptors. So this is the summary of the adrenergic receptors, which is very well given in your Tripathi. So you can refer to Tripathi regarding the location. So as I mentioned, alpha 1 receptors, they are present post-junctionally on the effector organs. So we discussed about how they are present on the GU, that is your gastrointestinal smooth muscles, then vascular smooth muscles, wherein they're causing vasoconstriction. On the glands, they bring about secretion. On the gut, they're going to cause relaxation. So you have selective agonists, which we're going to talk about. So these are the agonists. Alpha 2, on the other hand, they are predominantly autoreceptors, so they are present prejunctionally. Some of the postjunctional receptors, they are present in the brain, wherein they are going to reduce the neurotransmitter release. On the pancreatic beta cells, they're going to reduce the insulin production. So major action is the inhibition of the transmitter release, and they also, when they are present postjunctionally, they bring about vasoconstriction. So I was saying they are also present on the platelets where they cause platelet aggregation and a decreased sympathetic outflow. Then the beta 1, beta 2, and beta 3 receptors, we have discussed about it. Please remember, beta 1 receptors, they are present on the heart and the juxtaglomerular juxtaglomerular cells in the kidney, wherein they are going to regulate the renin, angiotensin, aldosterone pathway. Next is your beta 2 receptors, present on the bronchi, blood vessels, uterus, and so on. Beta 3 present predominantly on the adipose tissues. So this was what I was talking about regarding the uptake 1, uptake 2, and so on. So briefly, as a summary, we're going to see tyrosine gets converted to dopa by the action of hydroxylase. This step is inhibited by metirosine. So not much of a therapeutical or a clinical significance of this drug. Then dopa is acted upon by dopa decarboxylase, again non-specific, to produce dopamine. This dopamine is taken up into the vesicles by means of a transporter called as the VMAT, vesicular monoamine transporter. So this is in turn blocked by reserpine. So this reserpine it's a antihypertensive drug. It not just acts over here, it also acts at the norepinephrine transporters and the places wherein it's going to cause depletion of the neurotransmitters. So reserpine is an antihypertensive drug. So dopamine within the vesicle gets converted to norepinephrine by the action of beta hydroxylase. Okay, beta hydroxylase. And so here norepinephrine is stored as ATP um, along with ATP and substance P. Now, norepinephrine, again, on depolarization and calcium release, it is secreted into the vesicles synaptic cleft. So, this norepinephrine acts upon the adrenergic receptors present postsynaptically, or this can be taken up by the mechanism of norepinephrine transporter. So this is a place where most of your indirectly acting sympathomimetic drugs act. So this includes cocaine, which is a drug of abuse, and your tricyclic antidepressants. Please remember, TCAs are one of the major drugs for treatment of depression. So tricyclic antidepressants are going to inhibit this NET or your norepinephrine transporter. So because of this, there is enhanced levels of norepinephrine within the synaptic cleft, and these could be acting on the adrenergic receptors present postsynaptically. So this is the axonal uptake or the uptake 1, which is brought about by your norepinephrine transporter. Then you have what is called as the vesicular uptake. Vesicular uptake is nothing but which is mediated through your VMAT. VMAT. So this transports catecholamines which are from the cytoplasm to the interior of the storage vesicle, and this is inhibited by your reserpine. So I hope you have understood the summary of the adrenergic transmission. So the next thing is sympathomimetics. So we're going to talk about the drugs, also the adrenergic drugs, also called as sympathomimetics. Now these sympathomimetics are classified. There are many ways of classifying. So we are going to classify them based on three types. One is based on the chemical structure and where they are called as catecholamines or non-catecholamines, or they are classified based on the type of action into direct, indirect, and mixed action. Then we have the therapeutic classification, which is based upon the pharmacological actions and also the therapeutic uses. So we're going to study about all of these. The other way of classifying, based on the structure, it's like catecholamines and non-catecholamines. So amongst the catecholamines, so what are these catecholamines? Those which have a catechol nucleus. So they are classified again into endogenous catecholamines and synthetic catecholamines. So the three musketeers, whatever I told you, they are your endogenous catecholamines, and the synthetic ones, what we discussed so far is your isoprenaline. I told you a pure beta receptor agonist with no alpha action. So isoprenaline is a synthetic catecholamine. Along with that, you have dobutamine, which you have to remember, dopexamine and phenoldiazepam. Again, phenoldiazepam, it's a dopamine agonist. So these are some of the catecholamines. The next thing is your non-catecholamines. So these again, they are synthetic derivatives. Ephedrine is from Ephedra vulgaris, so it's a plant derivative. Amphetamine is again a CNS stimulant and a drug of abuse. So these are your non-catecholamines. Now, based upon the type of action, so either we have direct action, indirect action, or mixed action drugs. So, what do you mean by direct action? Those drugs which act directly on your adrenergic receptors, the alpha and the beta receptors. What are your indirectly acting drugs? The drugs which are taken up by your norepinephrine transporter, and they are going to displace the norepinephrine which is present in the vesicle. So because of this, norepinephrine can act, gets released from the vesicle and it can act. Mixed action drugs. So mixed action drugs are those which have both direct action as well as your indirect action. So mixed acting drugs are your CNS stimulants, methamphetamine, amphetamine, dexamphetamine, and so on. Now this is the classification which is given in your Goodman-Gilman. So it gives you like direct acting ones, So again, this is based on the receptors, their affinity to the receptor. So those which have selectively alpha action, selectively beta action, non-selective, which includes both of them. Adrenaline is a non-selective agonist at all of the receptors. Then you have the mixed acting drugs, what we discussed, amphetamine, methamphetamine, ephedrine, and so on, and indirectly acting. So indirectly acting, again, your mixed drugs like amphetamine, tyramine comes, uptake inhibitors like cocaine, then MAO inhibitors. Again, you're going to study about this in your anti-Parkinsonian class. Then again, COMT inhibitors. They are the drugs which inhibit the metabolism of norepinephrine. Now, therapeutic classification is the third type of classification, and this is purely based on your pharmacological actions. So, to understand the pharmacological actions, we have to understand one aspect, that is, your adrenergic and cholinergic system are functionally antagonistic systems. So, at all the organs, the receptors, muscarinic, nicotinic, on one hand, your parasympathetic system, and your adrenergic receptors, alpha and beta receptors, they are distributed. So both of them tend to act in balance, tend to act in an antagonistic way to try to maintain the balance. So whenever one system takes upper hand, as in case of flight or fight, it's the adrenergic system which takes upper hand. So the actions are they are similar, or they represent your adrenergic system over activity. So this is what you have to remember. But there is just one place wherein both of them act in conjunction. It happens to be your male genitourinary system, wherein erection and ejaculation are brought about because of your conjunction of alpha, your adrenergic action, and also your cholinergic action. So, talking about the pharmacological actions, I told you this is again a repetition of the things what we have discussed so far. Adrenaline is an agonist at these receptors. Noradrenaline has alpha action, beta 1 action, beta 3 action, but absolutely no beta 2 action. So you have to know that norepinephrine is not going to cause any amount of vasodilatation. So there's not going to be a fall in blood pressure because it is not an agonist at beta 2 receptors. Isoprenaline, on the other hand, has purely beta action and there's no alpha action at all. So each of these components or each of these catecholamines are going to have a differential action based upon the activity at these receptors. Now, adrenaline, what is it going to do? It's going to stimulate both the alpha and the beta receptors. So alpha receptors, it brings about vasoconstriction. So what happens? There's going to be an increase in the total peripheral vascular resistance. So this causes a rise in blood pressure. What happens when it stimulates your beta receptors? Beta 1 receptors, what does it do on the heart? It's going to increase the force of contraction, isn't it? So force of contraction, beta 1 activity. So it also enhances your heart rate. Excitability is increased myocardial contractility. So all of these is going to enhance the heart rate and also the stroke volume, which increases your cardiac output. So the net effect of adrenaline on the heart happens to be a raised blood pressure. On the other hand, norepinephrine, what is it going to do? So norepinephrine, it tends to increase the BP because of its alpha 1 and beta 1 action. So, when there is an increase in BP, I hope you remember the Mary's law, which says that heart rate is inversely proportional to your blood pressure. So, because the rise in blood pressure is going to stimulate your vagus system, and this brings about bradycardia. Whereas with adrenaline, even though there is a stimulation, there is an increase in the blood pressure, it directly also stimulates your nodes, isn't it? So SA nodal activity is increased. So this is in turn increasing the heart rate. So there is going to be tachycardia. With isoprenaline, what is it going to happen? No alpha action at all. Beta 2 action is prominent. So beta 2 action produces vasodilatation. There's going to be a fall in the mean blood pressure, more so with your diastolic blood pressure. So when the blood pressure falls, it's going to be stimulation of your carotid body, your basal-gyrus reflex, and this is going to bring about a reflex tachycardia. So you have to remember these things. The action is based upon the receptor distribution and the receptor specificity. So alpha 1, your vascular smooth muscle consists of both alpha receptors and beta 2 receptors. So I told you at higher concentrations, or when you inject parenterally, it is your alpha 1 receptors which have a very high sensitivity at higher concentration. So for that reason, the initial vasoconstriction is very much evident. Then as the levels fall, it's your beta 2 receptors which take an upper hand. So what is the action of beta 2? It is going to bring about vasodilatation. So this is going to reduce the total peripheral vascular resistance and also a fall in blood pressure. This vasodilatation is again mediated by the beta 2 receptors which are present in the skeletal muscles. The coronaries are supplied by your beta 2 and also in the liver, which brings about glycogenolysis. Vasoconstriction is mediated through alpha 1 and predominantly the cutaneous. When you are scared, you tend to become pale. It's because of blanking of your cutaneous blood vessels. It also happens at the mucosal and the renal blood vessels. So these actions are seen at the arterioles and the precapillary sphincter. So this was the effect of the blood pressure, which I've discussed already. Norepinephrine, it's going to cause a rise in both the systolic and the diastolic blood pressure. Because of the rise in BP, there's going to be a fall in the pulse rate. So peripheral vascular resistance is obviously very much increased because it has no beta 2 action. Epinephrine, all the receptors, a significant increase in heart rate mainly because of its direct action at the nodes. Rise in systolic blood pressure, a fall in the diastolic blood pressure because of your beta 2 action. Okay, and then isoprenaline, I told you the peripheral vascular resistance is totally falling mainly because of your beta 2, predominant beta 2 action. Next, this is one of the mechanisms what you have to know. This also comes as a 3-mark question, and you also have a 5-mark practical question. So this is something called as the biphasic response of adrenaline. So what is this? When you inject adrenaline rapidly IV, you can see a pressor response. Now this pressor response, or the increase in blood pressure, is mainly because of two things. One is your alpha 1 action and also beta 1 action. So increased stroke volume and increased total peripheral vascular resistance is going to increase the blood pressure. But as the concentration falls, it's your beta 2 receptors which become active. So beta 2 action is vasodilatation, and here you can see a slow sustained fall in blood pressure. So this is called as the vasodepressor response. This is the biphasic response. Now what happens? Post this biphasic response, you give an alpha blocker. So alpha blocker is going to block the vasopressor response. So what do you see? The unopposed beta 2 effect, which is going to cause just vasodilatation and a fall in blood pressure. This is the unopposed vasodepressor response. So this is called as vasomotor reversal of pain. So what is the implication of knowing about this? Because it helps us to understand the mechanism of action of vasopressors, which are used in hypotension or shock. Okay, so vasopressors have a role over there, and also cardiac stimulants. Now, the non-vascular smooth muscles. So I told you beta 2 receptors are present in your bronchial musculature and also on the uterus. So respiration, it tends to cause bronchodilation. So one of the primary drugs, adrenergic agonists, beta 2 agonists, salbutamol, salmeterol, they are your bronchodilators, which have a very significant role to play in the treatment of bronchial asthma. Then you have on the uterus, in fact, the pregnant uterus, the expression of beta 2 receptors are very high, and beta 2 has a uterine relaxant effect. So it has its therapeutic use as uterine relaxant. So again, salbutamol, terbutaline, isoxaprine, all of these drugs have beta-2, selective beta-2 action, which can be used as uterine suppressants or uterine relaxants. Now, why am I discussing all about this is we have one more classification called as therapeutic classification. So unless and until you don't understand the pharmacological actions, therapeutic classification, it becomes irrelevant. So for that reason, we are discussing the pharmacological action side by side. We are also deducing the therapeutic classification of adrenergic drugs. So the first thing, we have the vasopressors and cardiac stimulants based upon the alpha and the beta action of adrenaline and the other catecholamines. Second thing is the relaxant property at the bronchioles and the uterus, which makes them the much solicited drugs for treatment of bronchial asthma and also as uterine relaxants. Then, you know that they are also used as active mydriatics. So why are they called as active mydriatics? Because of their direct action on the alpha 1 receptors which are present at the radial muscles. So they are active mydriatics and they are not causing a loss of your light reflex. They are also the third line drugs for the treatment of glaucoma. So glaucoma is a condition wherein there's going to be a raised intraocular tension beyond 21 millimeters of mercury. So the main goal of treatment of glaucoma is to either reduce the aqueous humor production or to enhance the uveoscleral outflow. So adrenergic agonists, they are alpha 1 agonists, are known to reduce the aqueous humor, and beta 2 receptors are known to enhance the trabecular outflow. So this is why they have a role in treatment of glaucoma. Next, the metabolic effects, what we see, it has both a beneficial and a undesirable effect. You know why? Any kind of stress, you need that excess glucose to overcome the stress. But what happens? This becomes a double-edged sword. This in turn leads to excessive glucose production, which is going to tend to alter your profile. Okay, that is especially in diabetics, there's going to be dysglycemia. So one of the side effects which occurs when you give adrenergic drugs happens to be your dysglycemia. Then at the pancreas, alpha 2 receptors, they are going to reduce your insulin production. So all of these and also your adipose tissue beta 3 receptors are going to act and they're enhancing the lipolysis. What's the underlying effect of all of this action on the metabolism is mainly to give you that excessive or extra energy which is required to tide yourselves away from the crisis. So this is something like a compensatory response, but this compensatory mechanism itself can turn into a double-edged sword, which in turn leads to most of your side effects. Okay, I hope you understood this. Then you have the miscellaneous effects. So on the GIT, there's a reduced peristalsis. At the bladder, obviously there's reduced micturition. CNS, especially your alpha 2 receptors, they're going to reduce your blood pressure and anxiety. At the skeletal muscles, I told you it causes vasodilatation. Beta 2 receptors present in the skeletal muscles, they are the ones which give you energy to run away from the crisis, isn't it? But at the same time, what are they causing? They're going to cause tremors, enhanced potassium uptake, and this property is used for the treatment of a syndrome which is called as hyperkalemic familial periodic paralysis. So enhanced potassium uptake is responsible for treating this peculiar familial disorder. So at the spleen, enhanced RBC in circulation, definitely not of much clinical significance. So you can't be using it as a substitute to erythropoietin, definitely no. But these are the miscellaneous effects what you have to be knowing. So your adverse effects, side effects, they say, are your extension of pharmacological actions. So what are the side effects you can be experiencing when you give adrenergic drugs? So obviously they cause tachycardia. So this in turn leads to a lot of palpitations. Because of beta 2 action, you experience tremors, syncopal attacks. There could be precipitation of an attack of angina, especially in decompensated cardiac patients. Yeah, we spoke about tachycardia, tremors, um, Then the contraindications. Okay, so for the obvious reasons which I've mentioned, because of the enhanced cardiac contractility and the enhanced oxygen demand of the heart, it could be precipitating an attack of angina. And in hyperthyroidism, the heart is very susceptible to the action of adrenaline, which in turn predisposes the patient to arrhythmias. So even over there, you need to be very careful if you are going to prescribe a sympathomimetic drug. Obviously, you have understood the rationale of adrenaline in increasing your blood pressure. So in hypertensives, this may be causing a very significant rise in blood pressure. So again, caution need to be exercised while you're prescribing these drugs. Halothane with adrenaline, again, it's a combination for arrhythmias. I mean to say that halothane induced arrhythmias are very common. So you need to be careful about these adverse effects and contraindications. So I've come to the end of the first part of adrenergic neurotransmission. In the next class, I'm going to be discussing about the specific drugs which are of therapeutic significance. Along with that, we'll be discussing the therapeutic classification of adrenergic drugs. Thank you so much.